Hi, everybody. It's Professor Goodwin, Chapter 53, Med-Surg Nursing. And we are going to talk about coordinating care for patients with musculoskeletal disorder. Shall we? Let's roll. All right. So there are more than 50,000 Americans that have any kind of problems with muscular dystrophies. Okay. This can be present in any age, and the type and severity is correlated with age and onset. The most severe types of this are Duchenne's and Becker. Duchenne's affects about 1 in 10,000 of live male births and 3 in 100,000 of live female births. And most of those are genetic. Becker usually is males in childhood, and sometimes there is myotonic, which is common in adults. Don't know much about otherwise, though, muscular dystrophy. There are some inherited chromosome links, and the X chromosome is the only known associated factor. Okay, so the pathophysiology is essentially that there's a mutation of the dystrophin gene responsible for muscle repair. Okay, so it means that you have degeneration of muscles and associated weakness. It's progressive, so it continues to go. You can have muscle wasting and increased enzymes from some of the things that when muscles being deteriorated, like your CK, your lactate, your ALT, your AST. Those are liver enzymes. So these can be used in practice to get an idea for what the damage is or what the progressive deterioration is. Okay, so the clinical manifestation, the most common is chronic pain. Okay, and it's mostly in the lower legs. It can be very debilitating. When we're looking at muscle weakness, the main areas of the muscle weakness is in muscular dystrophy is according to what you're seeing here. Okay, so Duchenne's and Becker's is upper body and then legs, and for instance, congenital may be full body. So just take a look at these and make sure you understand the different types. So when you're doing medical management of this, it's difficult to diagnose. So the clinical manifestations are the same, but the muscle are not the same. So the muscle biopsy is really the gold standard. Is you get a biopsy of the muscle. Serum enzymes are an early sign, so you want to, if your doctor may check for that early. Imaging can also determine wasting if it's happening, and then some sort of kind of cardiovascular involvement or anything like that. Early screening is one of the ways we deal with it. Getting a diagnosis early, and then intervention is recommended by the CDC as soon as you identify it. So there's no cure for this. So all we can do is, as goals, is decrease the rate of deterioration, maintain functional ability if we can, reduce inflammation, and trying to regulate the metabolic pathways to decrease enzyme activity and muscle destruction. And then we can use glucocorticoids and glucocorticoids and glucocorticoids because they decrease the rate of deterioration and increase functional ability. And then we're going to treat the comorbidities. Sometimes you can see seizures or cardiomyopathies. And then, of course, there's psychosocial management because of the chronic disease state and how hard it is to live that way. Complications, you're going to see spinal deformities potentially. You can also have neuromuscular deterioration. What does that look like? Respiratory and cardiac compromise, right? So that can be an effect of something that you wouldn't consider in muscular dystrophy. So from our standpoint, our assessment and analysis is going to be around the clinical manifestations related to progressive muscle weakness and wasting. We're going to know that that's where our focus is going to be. So diagnosis for that, impaired physical mobility, right? That's associated with decreased muscle in the lower extremities as evidenced by an inability to walk independently. And then risk for dysphagia associated with decreased facial movement and or cranial nerve the seventh cranial nerve dysfunction, right? The next one, risk for falls. This isn't up here, but risk for falls associated with decreased muscle tone in the lower extremities. Next would be decreased cardiac output associated with AV node dysfunction. And then risk for ineffective breathing patterns associated with lumbar posture deformity. All right. All examples of things that you would use with this. All right. So nursing interventions. So number one, we're going to get the vital signs. We're going to see what's going on, because sometimes that can be the canary in the coal mine on where there's a dysfunction, and we can start from there. So that's going to mean you're going to want to get all the vitals, including O2 sats. You're going to look for any kind of change in what you would expect. Forced vital capacity. So the amount of air exhaled during a forced exhalation is a predictive value of pulmonary function. So we might try that. A chest x-ray. So a changing chest x-ray indicates potential for some sort of compromise from a respiratory standpoint, or changes in skeletal structure. Then we talked about labs earlier. You're going to have CK and liver enzymes elevated potentially, lactase. Let's actually lactic acid, aldolase lactic acid. All those indicate muscle breakdown. You might try, they might want to do a 24-hour urine creatinine clearance, because some of these muscle breakdowns can be hard on the kidneys. You might see an EKG, because the AV node disturbances can cause cardiac electrical compromise. The functional level, you're going to see a decrease in functionality because of the worsening progression of the disease. And then pain, which may be out of control. So you have to take a look at that. So first thing we're going to do is we're going to, if it's ordered, administer a corticosteroid. These are shown to decrease the rate of muscle deterioration and increase the functional abilities through decreased inflammation. The pharmacodynamic principles of this therapy focus on decreasing inflammation and regulating the metabolic pathways. Okay, things, and so the protein, the carbs, and the fats, may not be metabolized well. So you can maximize that, and then that enzyme activity reduces muscle destruction. Pain management, you can administer non-opioids like ibuprofen, Tylenol, aspirin, and ideally you can do that, and that can be effective so that you don't have to use opioids. Any kind of range of motion exercise would encourage maximum function and decrease potential contractures. These patients are always going to be on fall precautions because of the increasing weakness and the instability. You're going to have to keep an eye on them and follow the policies explicitly around falls precautions. Collaborative care with other caregivers, people like occupational therapy or physical therapy, social work, case managers, physicians, anybody that is important to be in the conversation. And as far as teaching, you're going to reinforce these exercises we've talked about. You're going to assist with comfort and mobility to try to increase their activity and delay further deterioration. Family members can be very helpful in recognizing signs, and you need to recognize signs of caregiver burden when those things can happen, right? So it's great that the family's involved, but it can also be very challenging on the family. And then as far as if you have muscular dystrophy, one of the things that the Muscular Dystrophy Association recommends is genetic counseling. As far as evaluating outcomes, promoting and maintaining optimal function and comfort, that's going to be your main goal. And talking about osteoporosis, we have 10 million Americans, 54 that have low bone density. So half the women and 40% of the men over age 50 will have osteoporotic fractures at some point. So the pathology is basically the bone is being lost because of decreased calcitonin, decreased estrogen, increased parathyroid hormone, bones and bones are porous at that point, and they can become brittle as well and increase your fracture risk. After the age of 30, these things start to happen in all people, believe it or not. Okay, so here's an example of what the bony changes. The changes would be in an osteoporotic bone. Okay, and the structure is just becoming thinner and more brittle. So first sign is usually a fracture, and prevention is the key. So you want to have a lot of weight training. You want to have a good nutrition around calcium and vitamin D, and weight training is really great for preventing bone loss. They can do bone density testing, and so that's sometimes used for screening. It might diagnose osteopenia or osteoporosis, and then they might even do a CT scan, which can measure the bone density of the spine and hip, and they also use it for diagnostic management. As far as medical management, the prevention and early screening, weight loss and muscle strengthening are huge. Healthy lifestyle, avoiding smoking, excessive alcohol intake, those are all things that you can do. When we talked about calcium and vitamin D supplementation, very important. Also, by the way, vitamin D can be achieved through sun exposure, right? So those are also options. Getting out there and exercising, taking walks. You're killing two birds with one stone there. And complications of this would include, like we talked about earlier, falls precautions. They're at risk for falls. They're at risk for a prolonged hospital stay, which comes with its own set of complications. And then, of course, death is something that can be an outcome of somebody that has a prolonged hospitalization. The longer you're in the hospital, the more you're going to deteriorate, right? Not to mention infection or whatever else. So it's pretty serious. From a nursing management perspective, we're just looking at the clinical manifestation, which is going to indicate bone loss of density and then, potentially fracture. So the risk for trauma would be one of the diagnoses associated with bone loss and the potential for falls and fractures. Impaired physical mobility associated with pain and musculoskeletal changes. So interventions for us, fall risk has to do with age and change in skeletal structure. It can result in deformity and disability. So these are correlated with falls and resulting fractures. Any fall in the hospital, whether it's witnessed, unwitnessed, assisted, unassisted, it's all going to be reported, and it has to be reported to the state and things like that. So it's a core measure, and it's going to be a major priority to prevent. And so you want to take that very seriously. Pain, the presence of pain obviously is going to limit our mobility if we're in pain, and definitely we're not going to be in optimal functioning. The nutritional status is also going to be important because adequate nutrition, including protein, vitamin C, calcium, vitamin K, magnesium, those are all important elements for bone formation and remodeling. So we're also going to want to know the level of activity and exercise, what they do, how often they do it, and the more active their lifestyle, the better. And then finally, body image disturbance. So skeletal changes can cause different scenarios, right? Like people that have really bad kyphosis, it can have a visual change. You can have lower extremity length changes and difficulty with clothing fitting appropriately, right? So all of these things can be associated with self-esteem. And it happens to all of us when we get older, these physical changes as well. But that doesn't mean you're okay with it. So it can cause those issues. As far as medications, one of the things that you might see is it's called a bis. I'm gonna mess this one up. Bisphosphonates, right? And so those impede bone reabsorption by inhibiting osteoclasts and absorbing calcium phosphate in the bone. I had to write that down. Um, and we talked about calcitonin and estrogen, parathyroid hormone. Okay, so all of the medications are going to be around trying to either prevent the loss of bone or promoting new bone formation. When you're teaching a patient on this, most important thing is take your medicine as prescribed. Okay, if you have some sort of GI disturbance or any other kinds of things that might keep you from taking it, you want to understand that. And you're going to also try to talk the patient into weight reduction if it's necessary, because that puts less stress on the skeletal structure. And then you're going to instruct them to incorporate supplements in their diet. Evaluating care outcomes. So we're going to identify the risk. We're going to determine their compliance with their medication, and we're going to encourage them to maintain a healthy lifestyle. That plan is going to give them the best chance for success. As far as Paget's disease, the epidemiology on this is 1% to 2% of white males. It's the second most common bone disease, more men than women. The risk factors are genetics and measles as a child. So 15 to 40% of the known causes or cases of Paget's disease are from genetics. There's an autosomal dominant trait that's more pronounced in the 5th to 6th decade of life. So these are people in their 50s and 60s. There's a link to genes from the measles virus, believe it or not. So what it's going to do is it's going to accelerate bone remodeling. So it's going to cause enlarged, disorganized bony structures, deformities, and fractures, Paget's disease. You'll see pain and deformity at the affected bone site, but the first manifestation might be a fracture. 80% of these are asymptomatic. So X-ray exams or radiological exams are helpful. Routine labs may identify something. The alkaline phosphatase will be elevated. And then history and exam are going to be important too. So history of fractures, you're going to look at deformities, pain, and family history, and all those things will be used to determine what's happening. For medications, the goal is going to be pain management and maximizing functional outcomes. So there's NSAIDs, there's opioids. You can take calcitonin to prevent the develop of tolerance. And then some of the same drugs we saw in the earlier one to prevent breakdown and encourage remodeling. So you can always have a surgical management of Paget's disease. So you can maintain the skeletal structure, hopefully, after the joint replacement or some kind of decompression. You want to maintain function, reduce pain, and then prevent some sort of paresthesia or paralysis if there's spinal involvement. Okay, so skeletal changes. So what you're going to see here is you're going to see some deformities, and in the skull might have some enlargement, which would affect the nerves in the brain. Also, dental problems, fractures, deformities. So all those things could be a situation you would see. And we're going to look at some of these. So bow leg, normal, and knock knee. So these are people that you would see in certain circumstances. And that's an indication of those things. So assessing this is going to be around the manifestations related to a disorganized skeletal structure. So you're going to either see it or test for it. And there might be because of the pain. So risk for trauma associated with bone loss and potential for falls and or fractures. So we talked about falls and fractures. The next one, acute and chronic pain associated with skeletal changes, vertebral compression on spinal nerves, and bone deformity. And then finally, impaired physical mobility associated with pain and or musculoskeletal changes. Makes sense. All right, so nursing interventions, we're going to be focusing on pain. They can reduce their weight to help. You're going to take a look at the serum calcium levels and try to get those up. They also might be on some other meds that might lower that, so you want to keep an eye on that. You want to put them on a fall risk for gait disturbances and assess on an ongoing basis whether they're safe. And then we talked about body image disturbance as well. So interventions, you're going to administer your medications as ordered. If there is some other types of therapy, like thermal therapy, you can, like hot or cold, you can, it's been shown to reduce pain and increase functionality. A support exercise program will start to implement steps to address physical and functional deficits. So physical therapy would be considered one of these, but exercises for strengthening abdomen or back muscles might be what you would see. Providing training on certain supportive mechanical items, things like providing training on orthotic shoes or braces and other supportive measures, and physical therapy can be consulted for that. Also, when you're discharging a patient like this, there's most likely going to be a home health component to it, or maybe even a rehab facility. So you're going to want to understand the home environment if they're going to be headed that way, because of their home could contribute to some of the falls potential, because the hospitals are fall proof in a lot of ways, right? We prevent things, but at home they might have rugs or anything that can trip them up. So the interventions with teaching, you're just going to tell them, make sure you're taking your medication. You're going to make sure that they're taking their supplements, and then exercise is going to be important for that as well. All right. So if you're evaluating outcomes, you're going to be thinking about the pain, maybe absence of fracture is your goal, and then absence of falls. Those are three outcomes that you're trying to ensure. Okay, so osteomyelitis. This is an infection of the bone, and it's 2 to 16% incidence with open fracture or trauma, including surgeries. It's most common in long bones. So you have what you would call the hematogenous, an infection spread from another area of the body, and that's most common in children under 1 year, and it's 85% of the cases. Then you have non-hematogenous infection, and that's an infection from an open trauma or a fracture, and that's about, like I said, 2 to 16% of the cases. Then you have chronic osteomyelitis, which would happen from things like diabetic ulcer, right? And just continues to be infected, and it doesn't go away. So the correlation with this has to do with the virulence of the infection, first of all, and then the immune status of the patient, whether they're compromised, the underlying pathology of what's happening, and then the location and vascularity of the issue. You need a place to invade. You get that inflammation, increased vascularity, maybe even a thrombus or ischemia, and then eventually necrosis. So here's what it looks like. You have your periosteum, and there's an initial site of infection, like for instance in a fracture. It's opened up, and then there's a chance for a bug to get in there, and then you start to get an abscess. So this is essentially an infection that has a pouch, or an infiltration of infection, doesn't have anywhere to go, and then it can start to cause disease around it, and then go closer to the rest of the bone, right? So you see necrosis on this right section, and that's all because of this ongoing infection. And so you have some new bone growth, but ultimately it's a very serious problem that takes a long time to get rid of. So the pain's not relieved by rest. So maybe it's always painful, right? It's not related to exercise. That's an important distinction, right? Does it get worse or does it always do that? There'll be swelling, potentially tenderness and warmth at the site because it's infected. You might have some signs of fever, chills, malaise. This is a patient who might come in with sepsis. So we're going to take a look at what is happening. You're going to get an ESR, an erythrocyte sedimentation rate, C-reactive protein, which assesses inflammation, and then you're going to be looking for positive blood cultures potentially. As far as the exam, you're going to look for soft tissue edema and any kind of other signs. You can do a bone scan. That's the preferred method. It's very sensitive. And but the only thing is the changes aren't noted on the x-ray until 14 to 21 days after this has already started. So, and then the gold standard really is biopsy if you have a concern and you're not sure. So they use antibiotics for this and opioids for pain, and then nutritional status around wound healing. This is the type of thing that you go home with a PICC line and you have vancomycin or something really serious, and maybe you're on that for months and months. So some people are, and it can have a negative effect on their organs. Okay, so you can actually go in and open somebody up and open the bone up and debride it, right? Clean it out, wash it out. So if the antibiotics aren't working, if there's an abscess, if there's a collection of infection inside the bone, if it's in a joint, if there are neurodeficits or spinal instability or an amputation necessary, these are all surgical interventions if necessary. And some of the complications I mentioned, sepsis earlier, amputation, squamous cell carcinoma, sepsis being the obvious one because you have an ongoing chronic infection. So when you're doing your nursing assessment and analysis, your clinical manifestations are most likely going to correlate with pain and with the extent of infection. So acute and chronic pain is normally associated with some sort of inflammation. And so the nursing diagnosis would be impaired physical mobility and associated with pain and inflammation. Peripheral neurovascular dysfunction associated with impaired perfusion to the affected extremity, and then risk for disturbance to body image associated with chemical or skeletal changes and bone deformities. Interventions. So in our assessments, we're going to take our vital signs. You might have an elevated heart rate or other signs of infection like a fever. Ooh, excuse me. You might have increased pain because of inflammatory process. The wound assessment might have redness, heat, purulent drainage if it's open, and then edema. With a neurovascular assessment, you might have weak pulses or pallor or paresthesia, numbness or tingling, paralysis. All of these things can be there because of a impaired circulation. And we'll talk about some of these things later when we get to compartment syndromes and things like that. And then you're going to get a WBC because you're looking for infection, obviously. The CRP, C-reactive protein, is for inflammation. And the SED rate is telling us how our immune system is doing. And then the blood cultures tell us what kind of bacteria we have. Okay, so here's what we're going to do. We're going to administer that IV antibiotics as ordered. Could be 4 to 6 weeks. We're going to take care of the pain if possible. That might be through thermal therapy as well. You're going to try to apply gentle range of motion exercises because you still have to be active, right? And then you can provide for a safe environment. So, preventing the falls and transfers while they're healing, as well as providing nutritional support and education And then they're going to need probably a home health agency because of their ongoing IVs. When you're teaching them, it's all going to be about pain management, antibiotic adherence, and the importance of it, and then the nutrition. They need to keep those serum levels up with that antibiotic in order to really kill it. It's something that can come back if they don't do a good job with it. All right. So nursing management, you're going to evaluate care outcomes related to the control of the pain. We want to resolve the infection, and then we want to preserve the limb. That's what you're looking at as goals. Okay, scoliosis. We talked about this earlier. That's an abnormal bend in the spine, and males and females have essentially an equal amount. It's 2 to 3% of the population, up to 10 million people in the U.S. 11% of people that are Caucasian, and half that are African American. The risk factors of this are smoking, obesity, elderly patients, maybe occupational, and then sedentary lifestyles. The patho around it is that you have patients with a neurovascular diagnosis, like cerebral palsy or things like that, or muscular dystrophy. And then you have congenital things like asymmetry that will be related to the anomality. And then you have, things like just a curvature in the spine that you might assess when it's less than, greater than 50 degrees. That's called Cobb's angle. It's unstable. And so greater than 60 indicates significant compromise to the thoracic integrity. And then there can even be cardiopulmonary compromise as well because the change in anatomy. Okay, so it causes uneven shoulders. One shoulder blade appears to be more prominent than the other, and an uneven waist. One hip's higher than the other, and potentially severe scoliosis can cause problems with, respiratory expansion, things like that. And here you are, you're looking at that. Okay, so medical management, we're going to do a visual inspection so that we can screen for it. We're going to look for radiographic imaging to get an idea. History and physical is going to be super important. And then we're going to quantify that curvature so we can monitor it in the future. Treatment can be around things like thermal therapy. There's growing research around exercise that it can actually reverse the symptoms. And then also prevent further progression. So that's huge. Females are 8 times more likely to need a brace or surgery. So exercise for them is particularly important. They're going to need physical therapy, et cetera, and exercise, and then pain management. You can do a spinal fusion. It's only considered when a patient has a Cobb's angle of greater than 50 degrees. All that spinal instrumentation and fusion in there, it's very drastic. So you want to make sure that the destruction that you're preventing has a less of a risk than the surgery itself. Okay, when we're assessing, we're going to assess the pain. We're going to see if there's a kyphosis, any asymmetry of the hip or shoulder, any prominence of the scapula on one side, asymmetrical leg strength, and any kind of heart or respiratory compromise. So our diagnosis look like acute chronic pain associated with curvature of the thoracic and or lumbar column, an impaired physical mobility associated with lumbar pain, risk for falls related to impairment of the vertebral column, risk for pathologic fractures associated with destruction of the bony matrix, and body image disturbance associated with change in posture. Vital signs, pain, and safety assessment during ambulation, things like increasing transfer safety. The increased curvature of the spine can cause balance and gait disturbances. Other actions, you're going to get your pain medicine on board as quickly as possible. You're going to get them to use a device and help them through accepting that. And then cold and heat therapy as ordered can be helpful as well. Okay, so if you're going to give them pain medicine, you want to educate them on what's happening with the analgesics, right? If you're going to give them opioids, they need to understand what they're getting. You can talk to them about braces and how that can, must be worn at all times, but can be very helpful. It can be a challenge when they're washing or changing clothes because of the brace limitations, but also in the event of a fall, you tell them they're going to need to provide communication right away to any of their physicians, because any kind of further damage can set you back quite a bit and you may not be aware of it. And then maintain their level of activity as much as possible. Okay, joint replacements. So in 2020, there were 800,000 total knee arthroplasties. Arthroplasty means knee replacement. And then 2 million total hip arthroplasties. So that's a hip replacement. Okay. Common areas could even include the shoulder, elbow, ankle, or wrist. And there are more women than men that get this. So osteoarthritis, you can have in your normal hip joint, ball and socket, and then you have this rough bone or bone spurs, worn cartilage, and that can be rubbing against that area. So you need to get that replaced. Same thing with the knee. You can have bone spurs or worn cartilage, narrow joint space in the meniscus. And so what they do is they can actually cut that out and replace it with a ceramic or titanium replacement. Now, what you're looking at here is just a narrow joint space due to a loss of cartilage, and that's in the hip. So here's what I was talking about earlier. You might just need trochanter replaced or the entire hip. And so there's resurfacing and preserving most of the bone. And then they put this attachment in there, and hopefully the bone will grow over it in time. With knee replacement, what they do is they can replace both sides or they can replace one side. Typically, the total knee replacement they call this one a partial, right, on the left-hand side. The total is usually better because it's not structurally inconsistent, although the partial is associated with less complications. They're both very safe, but and also we actually can 3D print some of these replacements, and so with that comes a greater degree of accuracy, and so the partial can be very helpful as well. The diagnosis, it's usually based on deformity or some sort of trauma report, loss of function, stiffness, pain, atrophy, and all of that's going to be handled with an X-ray or an MRI. Complications, it could, bleeding could be a problem. Infection, even potentially, if it's some sort of trauma, especially if it's open. Blood clots can happen. So those are all things you want to be aware of and take it seriously. So nursing management is going to be around the clinical manifestation and the degree of changes in the joint. Diagnosis would include acute or chronic pain associated with the destruction or deterioration of the affected joint, activity intolerance associated with the limited physical mobility and progressive pain, and risk for infection associated with surgical site infections. Assessments, you're going to do your pain assessment. That's going to be a key one because that's the main indicator of what's happening. After the operative case, you're going to do an assessment of all the vital signs and all those things, of course. But you're also going to be looking at temperature. You're going to be looking at pain levels, laboratory assessments. Then you really get into what's important is the neurovascular and musculoskeletal access. So, is there any pallor? Do they have any paresthesia? Any dysfunction that seems like it might be indicated? And then they're going to look at things like the wound drainage as well. Our actions would be around making sure they're getting their medication, making sure if there is a wound, it's cared for according to our instructions. You'll see that, particularly in knee surgeries, they'll do this thing called ERAS, early recovery, ERAS, enhanced recovery after surgery, where they have a bundle of things like high carbs and early ambulation. They're all associated with getting you home faster. So there's going to be early mobilization for you to get you up and moving. Usually within 6 hours, they want to get you up to a chair and then going from there. Okay. They might have SCDs. They might call them scuds. They might just call them leg squeezers. So anti-embolic stocking is just the compression socks. And then the sequential, I can never see it. SCDs, sequential compression device, is the venous squeeze, the calf squeezers, right? So you might have a anticoagulant, because not only are they at risk for DVT, they're also at risk for some sort of pulmonary embolism or even a fat embolism, which is a risk in this surgery. And then we're going to, if it's necessary, we're going to follow our continuous passive motion requests. We're going to make sure that our consults are being adhered to with physical therapy. And then we're going to maintain whatever positioning and turning schedule they have so that we can do a good job. Adduction pillows can help prevent the dislocation. A patient that just had a hip replacement, you're going to be very careful with any changes, right? For obvious reasons. Preoperative teaching is going to be around helping them understand what they're in for, what's going to be coming. Do they have the support? And like I said before, things like opioids or DVT or fat embolus, those are all things that they will be aware of because of their surgical consent. And then, let them know why they're getting the anticoagulant, et cetera. And then post-operative, they're going to be talking about what to do as far as wound care, keeping their diet high in protein, and staying away from things like vitamin K, which can limit the effect of blood thinners. Okay. And then, of course, the home management aspect is going to be probably the biggest planning that goes on before discharge. Our goals are going to be reducing pain and restoration of what is a normal functioning for them. You're not going to see that during their hospital stay, but that's where we're headed. Okay. And going into bone cancer. So this is the most common it's estimated 3,900 new cases. It's not the most common, but it's 1% of all cancers, fifth most common in adolescents and young adults, not the first. So in osteosarcoma, you're going to look at abnormal cell overgrowth around the bone. Okay. And it's not really restricted. It's just undifferentiated cell growth around the bone. You're going to see pain, swelling, redness, decreased range of motion, fracture. All of these things will be sometimes overlooked in the assessment. And so those are all some things that will delay the diagnosis potentially. So we're going to get a good history and physical. We're going to get some labs, CT scan probably, and then that'll tell us whether there's any metastasis. So you might even get a bone biopsy, but those labs might be the tip of the iceberg as far as telling you that there's something amiss. Treatment is going to be, if you realize it, pain control and then destroy the tumor. Whether you want to salvage the limb, obviously, you want to survive. maintain quality of life. So you might get radiation or chemo or surgery. All of those things would be used to try to minimize that situation. So surgery means they're going to resect that tumor and they're going to try to save that limb, or maybe they potentially might have to amputate it. Okay. And they're going to put implants if they need to inside that bone, or reinforcements. They can do that as well. They can even bring an allograft, which is some sort of specimen. And then they might even be doing an autograft from another area of your body. As far as complications, it's the same as any cancer. You can lose the arm or the limb, you can die, and a whole litany of things in between. It's pretty rough. As far as our assessments go, we want to take a look at any kind of soft tissue masses or pain. It's most likely what we'll see, but maybe not a whole lot else. The diagnosis you would see around this, acute chronic pain associated with the destruction of bone, impaired physical mobility associated with pain and inflammation, peripheral neurovascular dysfunction associated with the impaired perfusion, grieving associated with impaired body image, and risk for pathologic fractures associated with the destruction of bony matrix. And that impaired body image might even be because they lost a limb, right? Or something along those lines. Assessments, we're going to take a look at everything we would normally look at. Pain's going to be a big one. Depending on the compromise of the bone, you might have neurovascular changes. You're going to palpate anything that you can feel on a mass or any kind of tumor growth. And you're going to keep an eye on their level of activity, which is going to be important, particularly if it's becoming more severe. So we're just going to administer the pain medicine as ordered. We're going to help them through chemotherapy and radiation. We're going to support and advocate and help to position their affected extremities. And then any kind of thermal therapy, just for more like for comfort, is going to be what we help with as well. Too much talking, my voice is going away. All right. So nursing interventions, when we're teaching a patient, it's going to be all about what they can expect from their medications, what they're about to go through in radiation, how important nutrition is, safe movements that they can perform without risking their mobility or anything like that, and then what the disease course could look like. This is a sensitive conversation, right? You have to have a lot of trust. Evaluation, we want to save that limb. We want to keep their pain under control. That's what we're trying to do. So case study here. Eileen Doherty is a 55-year-old female who presents to her healthcare provider with complaints of increasing difficulty in walking and increasing pain in her lower back. She shows early signs of kyphosis in her posture. She's currently on no medications and states she has a multivitamin and calcium supplement when she remembers them. Eileen has annual checkups with her healthcare provider, and despite her relatively good health, she's concerned about the recent pain and resulting limitations in her activity level. So what do we think about that? So episode 2, she's returned to her healthcare provider with complaints of increasing pain in her lower back and feeling like I could fall while walking. Her kyphotic posture appears to be worsening, and when her height is measured, it's noted that she has a decrease from 5'3" to 5'2.5". Over the course of a year, she remains on her medication regimen of multivitamins and calcium and states she has begun to take naproxen for the pain. She's very concerned about her fear of falling, increasing level of pain, and decreasing level of function. She demonstrates classic signs of osteoporosis. She states she has noticed that her pants seem longer. She complains of back pain, increased difficulty with simple activities of daily living, such as short walks. Initial diagnostic results reveal an elevated ESR rate, decreased serum calcium, and a T-score minus 2.5. for a BMD study. These results are consistent with primary osteoporosis. The healthcare provider orders her to begin biphosphonate therapy, Boniva, by month. She demonstrates the need for more teaching by which of the following statements? She says, I don't need to take calcium or vitamin D anymore. I know I need to develop an exercise plan. I may need to remove a lot of small throw rugs, or I know I will need to follow up on a regular basis. What do we think there? Well, all of these are pretty good. I know I need to develop exercise. I need to remove small throw rugs. I need to follow up on a regular basis. Okay. How about A? I don't need to take calcium or vitamin D anymore. That would be my guess. Yeah, I guess that's what it is. It's A. Number 2, the nurse understands which screening tool will help evaluate home safety. So there's a screening tool that helps with this, and the activity level that's essential to this is called what? Is it is it a screening tool for medication, dietary, or activity? No, it's going to be a screening tool about activity levels, right? The components of care. So that would be fracture risk, so FRAX. Okay, in case you didn't know that. Her greatest risk factor for developing osteoporosis is which of the following? A low BMD, a high BMD, low FRAX, or a high QCT. Okay, so low bone mineral density test is a good predictor of fracture risks. A low FRAX indicates low fracture risk, and a high QCT indicates strong bone. So I think we're going to say that should be a low BMD. The nurse understands which of the following is an important teaching point for Miss Doherty. Boniva must be taken on an empty stomach. It's taken once a week. May cause joint pain. It's taken instead of calcium. The one thing about Boniva is that it causes GI irritation. So it should be taken on an empty stomach. And it's taken once a month, so it doesn't cause joint pain. And it shouldn't be taken with calcium. Okay, the nurse understands which of the following is implicated in the development of osteoporosis. Increase in calcitonin levels, decrease in estrogen, decrease in parathyroid, decrease in phosphorus. A decrease in estrogen inhibits bone formation, right? So it's going to be B. And the nurse understands which of the following is implicated in the development of osteoporosis. I think we saw this one already. Hang on. Okay. So making connections. What clinical manifestations of osteoporosis are observed in this patient? So, well, it sounds like she's having increasing pain in her lower back. Feels like she's gonna fall, right? Her kyphosis appears to be worsening. She lost a half an inch apparently, and her ADLs seem to be changing in a negative manner, right? So those are all things that we would think of. How do the clinical manifestations correlate to the underlying pathophysiology? I guess the bone loss, which is consistent with her loss of height over the last year, would be one. Decreased bone mineral density, which is causing changes in her kyphosis and skeletal structure, would be what I would say for that. What could happen if osteoporosis is not effectively managed? Well, she's going to be at a greater risk for falls and fractures, and those things at her age can be life-threatening or can facilitate the end of life. What treatments are included to manage this patient's osteoporosis? What's the rationale? Well, we can encourage weight loss. If she's a smoker, that's going to be important. good nutrition, limit alcohol intake, strength, weight and strength training, and then of course medications and supplements. What are the priority interventions for this patient? Well, let's see. So, well, we already see. Okay, what findings demonstrate the treatment plan is effective? Well, ultimately, there's no worsening of the bone structure. There's no changes to the scan. We're going to monitor the labs, including estrogen and calcium and vitamin D. No major falls or fractures. Then we're going to watch the overall strength. So, weight strength and fatigue, and then coordination, potentially with her musculoskeletal damage. Those are all things we'd think about with that. Okay. And with that, we are all done with our lecture and we'll be moving on. I hope that this has been helpful for you and we'll talk soon. Thanks.